Good day. I'm Dr. Anthony Pottinger, and this morning I'll be giving a brief talk about medical cannabis in the treatment of cancer and chronic inflammatory conditions. All right. Cannabis has always been a medicine, probably used by humans since before the dawn of civilization. For the thousands of years prior to the invention of modern chemistry, plants were all we had in the way of medicine. Cannabis is listed in the oldest known Chinese pharmacopoeia, which is believed to be based on earlier texts as much as 5,000 years old. Side effects are relatively mild and short acting, and there is no lethal dose. Its mechanism of action was an unsolved mystery until the discovery of THC, delta 9 tetrahydrocannabinol, in 1964. The first cannabinoid receptor, CB1, was discovered in 1988 in a rat's brain. It's mainly found in the central nervous system. The first endocannabinoid, named anandamide, which is from the Sanskrit word anandan, meaning inner bliss, was discovered in 1992. It is a fatty acid agonist for both CB1 and CB2 receptors. The second endocannabinoid, A2AG or 2-arachidonyl glycerol, was discovered in 1995. The second cannabinoid receptor, CB2, was discovered in 1993 in a rat's spleen. It is mainly found in the periphery, i.e., the heart, the liver, pancreas, skin, reproductive tract, the immune system, etc. An endocannabinoid is a chemical that is produced in the body that is agonist on the CB1 and CB2 receptors. A host of phytocannabinoids were discovered in the 1960s. Thus far, researchers have identified over 100 phytocannabinoids. A phytocannabinoid is a chemical that is produced in the plant, which is an agonist or partial agonist on the cannabinoid receptors CB1 and 2. The main two phytocannabinoids are delta 9 tetrahydrocannabinol THC and cannabidiol CBD. The overwhelming preponderance of research focused on psychoactive THC. Only recently has renewed interest been manifest in THC analogs like CBD. Each phytocannabinoid produces a distinct action in the human body, while different combinations and ratios produce yet another range of distinct actions. The plant produces other medically active substances called terpenes or terpenoids. These are responsible for the aroma of the flowers. A third group of chemicals called flavonoids are called flavonoids. These are responsible for the color of the flowers. When the whole flowers are used to make extracts, it's believed that there is synergism between the cannabinoids, terpenoids, and flavonoids. There is a widely held view in some cases plants are better drugs than the natural products isolated from them. This is called the entourage effect. Let's just look at a few points concerning THC. This is the most common phytocannabinoid in the original plants. Why I say original plants is because you have plenty strains now which have been genetically modified, example, to breed down THC and to breed up CBD for use as medicines like in children or young adults, where there is some worry that if these young people use THC, it could somehow hamper the development of their brain. So you have strains now that are mainly CBD and very little THC. It is a partial agonist at CB1 and CB2 receptors, and it is analogous to anandamide, all right, which is the endocannabinoid, and this underlies many of its activities as a psychoactive agent, an analgesic, a muscle relaxant, and antispasmodic. Additionally, it is a bronchodilator. It is also a neuroprotective antioxidant. It is antipyretic agent and works well in cholestatic jaundice. Um, it is over 20 times the anti-inflammatory power of aspirin and twice that of hydrocortisone. THC is likely to avoid potential pitfalls of either COX-1 or COX-2 inhibition, as such activity is only noted at concentration way above that attained therapeutically. THC is also cytotoxic in several tumors, especially brain cancers in the mice and rats. When THC was injected in the tumors, the cancers died with no damage to normal brain tissue. This was first discovered in the University of Virginia way back in about 1974 and was rediscovered in a lab in Madrid 20 years later. The mechanism of action is fivefold. It is anti-proliferative effect. There's anti-angiogenic effects that mean make new blood vessels. It's anti-metastatic effects mean leave where it starts and spread elsewhere. You have apoptotic effects mean program cell death. Each cell can divide a certain number of times before it becomes what I call a senile or senescent cell and should die. If this cell don't die, it just creates a lot of chronic inflammation via cytokines and other things and can be very deleterious. And there is also autophagy that THC can cause with the cancer cells. I will touch on this a little later in the presentation. THC and CBD work synergistically in killing cancer cells with no damage to normal cells. Let's just look a bit at cannabidiol CBD. CBD is the most common phytocannabinoid in fiber, what is called hemp, and it is the second most prevalent one in marijuana, stroke ganja. It's proven extremely versatile pharmacologically, displaying the ability to antagonize THC at CB1 at low concentrations. This attenuates the adverse effects of THC, such as anxiety, tachycardia, hunger, and sedation. CBD is an analgesia, is a neuroprotective antioxidant more potent than ascorbate, that's vitamin C, and tocopherol, vitamin E, without COX inhibition. CBD is an antagonist at certain receptors and possibly supporting a therapeutic role in disorders of cell migration, notably endometriosis. CBD is anticonvulsant. This is probably the most famous use of it from the Charlotte's Web videos that came out about 10 years ago. All right. It is also anti-nausea. It is cytotoxic in breast cancer and many other cell lines, while being cytopreservative for normal cells. It antagonizes tumor necrosis factor, one of the main mediators of chronic inflammation. This is a cytokine. And that was discovered in a rodent model for rheumatoid arthritis. It prevents prion accumulation and neuronal activity. Prion are certain proteins that exist like in the appendix that can travel along the vagus nerve back to the brain and is associated with certain conditions such as Creutzfeldt-Jakob disease and possibly even things like Parkinson's disease. CBD also display powerful activity against methicillin-resistant Staphylococcus aureus. All right. So these are bacteria that can develop resistance to penicillin, particularly methicillin, and it can be very dangerous. And CBD shows good activity against it at a fairly small concentration. In 2005, it was discovered that CBD has agonistic activity on serotonin receptors, 5-hydroxytryptamine receptors. This explains its anti-anxiety activity. It has shown promise in the reduction of strokes. CBD inhibits synthesis of lipids in sebocytes. Those are the cells that form sebum and are also causing acne, which produces apoptosis at higher doses in a model of acne. CBD is synergistic with THC in treating intractable cancer pain patients unresponsive to opioids. There is a 30% reduction in pain from baseline, and this was even better than using high THC extract alone, which was indistinguishable from placebo effect. There is true synergism of THC and CBD in pain, which is greater than the summation of both separately. Now let's look at cannabis and cancer. If you are expecting me to present data from controlled randomized big trials that are properly powered, then you will be disappointed in just about anything that I have to say. This is because there are no such trials. Cannabis, marijuana, has been demonized starting in the USA from the early 1900s. There are many reasons for this, which I cannot get into now. We may have to look at this history in another presentation. In 1971, it was placed into Schedule 1, i.e., the same category as heroin, cocaine, LSD, methamphetamine, basically meaning it is a dangerous drug which is prone to addiction and with no medical properties. Because of this, it was and is almost impossible to do proper research. You could not get ethical approval. In the USA, only one agency was allowed to provide plans for medical research, i.e., the National Institute of Drug Abuse, NIDA. This agency has refused to fund research into the medical benefits of cannabis, claiming that its charter allows it only to fund research into the harms of drug use. Hence, I cannot tell you that X dose of THC, CBD, or marijuana at Y interval for Z duration will cure your brain cancer, prostate cancer, ovarian cancer, or breast cancer. This is what most doctors are looking for. This is how we were trained. This is allopathic medicine. And more we are finding out that it should not be an all or none principle. There is a place for anecdotal information. Aspirin, antibiotics, and many more early drugs didn't have a controlled randomized trial before being adopted as medicine. There is a place for alternative or better integrative medicine, which combines conventional treatments with complementary ones. In my practice, I use the cannabis oil that we make to complement my surgery, chemotherapy, and radiotherapy. It is beneficial to many patients who are suffering intractable pain, even while on narcotics. It is beneficial for those who cannot sleep, those suffering from overwhelming anxiety, panic attacks, poor appetite, post traumatic stress, excessive ruminations, and bad memories. In the right dose, I am sure it's cytotoxic because I've seen it many times. But as usual, the pure allopaths will dismiss it as anecdotal or placebo effects. I will give a few examples from real patients. There was a lady in her late 40s with an end stage metastatic breast cancer in one of the hospices here, and she was on high doses of morphine. She was suffering from chronic constipation, had no appetite. She was skin over bones. She was cachexic. There was no hope, just waiting to die in days or at best a few weeks. Her husband heard me on the radio talking about cannabis one Tuesday night and brought her and her father to me 2 days later. After explaining all, they decided to try the oil in the manner I outlined. 2 weeks later, she was discharged from the hospice. She was off the morphine, having bowel motions, increasing appetite, gaining weight, and was no longer waiting to die. At 2 months, they brought her to see me again. It was a different person. She was now willing to start tamoxifen, or her original cancer, which was diagnosed over 10 years prior, had estrogen, progesterone, and HER2 receptors. But this lady was very intransigent, didn't want to use any of the traditional treatments, and were using things like herbs and acupuncture and aromatherapy and things like that. So I am not saying we should throw out allopathic medicine, because there are certain things that, it should definitely be the frontline treatment. In this case, this lady, if she had done traditional treatment, should have been cured, because the cancer was picked up at an early stage and a really small size. However, it progressed over the 10 years, and the treatments that she were using. She was living outside of Trinidad. I don't want to give too much information that possibly somebody could hear this and identify who it is. But they returned to Trinidad basically to die. So after 2 months, she was now willing to try some form of conventional management. So I started her on tamoxifen, 40 milligrams daily. The traditional dose is usually 20 milligrams for maintenance. But I started her on 40 milligrams, and she continued with her cannabis oil, titrating the dose upwards. She was alive at 1 year after the first visit. Then I lost contact. My receptionist could not get in touch with her or the husband from the numbers that we had. So I don't know if she transitioned and then he migrated, or if they migrated or what. But she was alive and well for at least 1 year that I can speak of. There's a man in his 70s who presented with metastatic bladder cancer and BPH. He was treated with some amount of surgery. Didn't remove the bladder, but they resected most of the tumor, and then he had radiation and so. But the tumor persisted and spread. So by the time he came to me, he had mets to his spine and things like that. He had chronic pain, frequency, nocturia, hence insomnia, chronic exhaustion, poor appetite, lost the will to live. His partner is a long-standing patient of mine. So I explained all that they needed to know, instructed them how to use the oil, and how best to follow up to see if there's any improvement. Prior to my visit, he had several CT scans showing the volume of the prostate, which was about 135 cubic centimeter, and there was thickness of the bladder walls, and there were bony mets. By 2 weeks, his symptoms were all improving significantly. Pelvic ultrasound at 3 months showed prostate volume down to 107 cubic centimeter. The thickness of the bladder wall had decreased. He continued to use the oil as instructed. After 6 months, the volume of the prostate was 93 cubic centimeter. And at approximately 9 months, it was down to 87 cubic centimeter. And the thickness of the bladder wall was now normal. He transitioned after 2 years from the first visit, but had a much better quality of life. His partner and adult children are very thankful for his last 2 years. Finally, a lady in her 40s, she was actually 44 when she presented, with stage 4 ovarian cancer, and was admitted to the hospital that I work through the accident and emergency department. CT scan showed massive tumor load in the pelvis and upper abdomen, extensive ascites, shortness of breath, anemia, chronic pain, insomnia, exhaustion, wasting. She had staging and debulking laparotomy. It took me 6 hours to optimally debulk her. In a case like this, optimally debulking means by the end of the surgery, there is nothing visible to see which is greater than a centimeter. The goal is actually to leave nothing that we can see. But if people have miliary disease, you can probably take out 1,000 or 2,000 small tumors. But once you don't leave back anything bigger than a centimeter, these will respond very well to just about any adjuvant treatment, whether it be chemotherapy, hormonal therapy, immunotherapy. And that treatment have to be done within a certain time period. I try to start adjuvant treatment by 4 weeks post-surgery. Shouldn't go beyond 6 weeks post-surgery. If you go beyond that, the cells that leave back that you probably can't see, or small volume nodules, can start to grow significantly, and then we lose the benefits of the debulking surgery. I started combination chemotherapy 4 weeks post-op at high doses of paclitaxel and carboplatin. After the third cycle, her CA125, which was more than 10,000 prior to the surgery, was down to 267. She had 3 more cycles, and after that, her CA125 was at 46.5 units per mil. At 7 months post chemotherapy, her CA125 increased to 1,060 units per mil, indicating that the tumor was regrowing. CT scan essentially normal, except for bilateral pleural effusions. I drained the pleural effusions and re-challenged her with the same two jugs. So I challenged her again with carboplatinum and Taxol. And as anyone who dealing with cancer would know that once the first line treatment, you get a response rate of around 80%. But once the tumor recur, you treat with the same drugs again, the response rate is less. If that recurrence is before 6 months, usually the cancer has developed resistance and you have to go to second line drugs. But once the recurrence is after 6 months, you could try the same two drugs again. And this combination is effective and well tolerated. So the only difference this time around, same two drugs, same doses, but this time I added the cannabis oil, titrating the dosage upwards based on tolerability. After 3 cycles of chemotherapy, her CA125 was 34.2 per mil. This should not happen because I just said the response on the second line treatment and the second course should be better than the first. And even after 6 cycles on the first, the CA125 was higher than what it is now, which is 34.2. In my simple mind, I was thinking, how else can this be explained except that the cannabis was synergistic to the chemotherapy? After 6 cycles, her CA125 was 36.68. She had progression again 6 months after the second course of chemotherapy. Didn't want to use any more chemo, so we decided to use the cannabis oil as maintenance therapy. But she was on a high dose of 10 mils per night. The usual patient using 1 mil or 2 mil, but she tolerated it very well. All right, this maintenance dose of cannabis oil continued for 27 months. Long story short, she transitioned 3.5 years after initial diagnosis of stage 4 high grade serous ovarian cancer, which is usually a death sentence. Finally, I it was discovered, as I said previously, in 1974 at the University of Virginia that THC injected into brain tumors of mice kill cancer called gliomyoma, glioma, without any injury to normal tissues. Now, this is an improvement upon chemo. Chemotherapy does not discriminate between the cancer cells and normal cells. The NIDA shut down the study and suppressed the information. This information was rediscovered in Spain at the University of Madrid 20 years later. The cancer cell membranes have more cannabis receptors. High potency THC binds more to the cancer cells than the normal cells. This sets off a series of reactions in the cancer cells, one of which is an upregulation of the function of lysosomes, which autodigest, i.e., autophagy, and kills the cancer cells. This has also been demonstrated in breast cancer, prostate cancer, melanoma. Let's just look at some of the chronic situations in which cannabis is very helpful. Cannabis and hypertension. The underlying cause of most of what we call essential hypertension is due to chronic inflammation. There is a close relationship between type 2 diabetes mellitus and essential hypertension because both are due to chronic inflammation. Cannabis is well known to be anti-inflammatory by decreasing the production of cytokines and by also modulating their actions. This anti-inflammatory effect will be beneficial in just about any disease which is caused by chronic inflammation, i.e., type 2 diabetes mellitus, so-called essential hypertension, osteoarthritis, heart disease, and all autoimmune diseases. Let's just touch on a little bit of diabetes. It is well known that there are substances in cannabis that can reduce blood sugar. At least one has been isolated so far, THCV. This could be dangerous, especially for type 1 diabetics. All right, for if they take their usual dose of the insulin and then they use cannabis, because the cannabis can increase the sensitivity of the insulin receptors. It will make the insulin they took more efficient, and it could push the blood sugar down to dangerous levels. All right. And there, in the young people who are type 1 diabetics who use cannabis regularly, there is an increased risk of diabetic ketoacidosis, which could be lethal. Most people who use cannabis tend to be slimmer. This applies to diabetics and non-diabetics. Clearly, there are effects on the metabolism that is causing this that we don't really know of as yet. There is evidence that cannabis can increase insulin sensitivity, hence, continuous glucose monitors are important in the management of diabetes, especially in type 2. Now, we'll stop here. I hope some of what we have said this morning would be of some kind of benefit to someone, increase their knowledge of cannabis and some of the potential use of this very wonderful plant.